risk assessment is of paramount importance because we need to know what types of medications we're going to use and what, for how long, and what combination. There's so many medications we can use. There's so many things patients can do or have to do. And there's always the tolerability, the need, the duration of time, the patient selection. Is all medications required for all patients, or can we trim them? And we can, if you want, individualize them a little bit. I think this is always attractive for both doctors and patients, both the procedural doctors, if you want, if patients having a procedure or surgery, as well as the clinical doctors who take care of the patients in the office in the aftermath. Yes, of course. First of all, let me congratulate the European Society of Cardiology for putting out this criteria. Until recently, we're mostly focused in a bleeding criteria, if you want, like adverse event related criteria. This set of criteria of thrombotic risk, of ischemic risk, came out of a professional society highlight that there are efficacy criteria as well, like in trying to prevent something from occurring, not just averting a side effect. And they classified the patients or by this criteria into low risk if they had none, into moderate risk if they had few of the clinical risk factors, such as, for example, diabetes or renal failure, just to name a couple, and then high risk if they had a combination of several clinical factors plus angiographic factors such as extensive coronary disease, many stents placed or required or complex stent procedures, etc. So they sort of make sense, I would say, from clinical point of view, from clinical cardiology and interventional cardiology point of view. The questions we came about is, okay, well, this come from European studies for the most part. Couldn't this be applicable to our current practice in the United States? And could this be only with patients with acute MI, or maybe can be applied a bit more general in patients with similar syndromes? And we interrogated, or we looked at the database of the interventional cardiology procedures in our centers. We have very many patients we found over 10 years of 2012, should say, until the completion of 2019, exclusive, of course, of the subsequent pandemic era. And we classified them. And interestingly, first of all, the breakdown was rather good. About 45% of the patients were sort of in the middle, moderate risk, 22% of the patients were low risk, and about 33% were high risk. And the total number was nearly 12,000 patients. Well, clearly, we had a lot of patients in our analysis. When, of course, these different risks have very different characteristics anyhow, for the obvious reasons. There are low, medium, and high risk, so they are supposed to have many differences. So we looked into the rates of adverse events, and we found a very nice correlation between the criteria as set out by ESC and the percent of major adverse cardiovascular events that our patient had, grading between 1.6 and 5.5% at 1 year, incrementally in the three groups. And even actually the more powerful correlation was the all-cause mortality from 0.6 to 2.7% in increments. So obviously one can see that this criteria, although generated in Europe, they are quite applicable in our practice. The overall correlation is at 61%, which is deemed adequate for these types of things. And in subsequent studies, we're going to look into developing perhaps some adjustments or calibrations, as we call them academically, of these risk factors, perhaps identifying something that might emerge more from our data that might, if you want, add on or enhance the profile of this classification. Most interesting was that the mortality trended together with the major adverse cardiac events. There is a significant discussion of the past years that whether the procedures we do have something to do with mortality or only for repeat procedures or patient well-being, etc. It looks like the overall major adverse cardiac events, which comprises many different endpoints, and the mortality seem to be quite concordant in this analysis. I think this is very interesting because by utilizing this analysis, we're targeting not only patients who have higher disease burden, if you want, or higher angina or need more procedures, but we're targeting or knowing the risk of survival or mortality, and in order to enhance the chances of survival of our patients. I think that is a very important, that how concordant the major adverse events with mortality alone were. Well, the limitations, of course, is that we would like to be assessing those aspects prospectively, and we did not apply all the criteria set by ESC because it was not possible to find few of the, I must say, rather rare conditions, but still we could not locate them, such as the duration of the antiplatelet therapy, any adverse events such as stent thrombosis that have happened on antiplatelet therapy from the get-go at the time of the procedure, and the patient adherence and how that relates to the risk as well as to the different outcomes. Also, the specific type of clinical presentation could be broadened to include perhaps even higher risks of patients in subsequent analysis. The keynote is the key message is that we should look into not only bleeding risk, but also thrombotic risk and angiographic risk. The thrombotic risk is related to basic criteria that patients always possess, but is also modified or has a lot to do with criteria that include the type of procedure we do, how complex the procedure was, how well it was executed, and how complex disease in general, as far as atherosclerosis and stenosis, if you want, in the coronary arteries the patients possess.